The inflatable, as I told, what is the best for this implants is we will get the very good erection and we'll have higher satisfaction rate along with the superior conceivability, flexibility. So that is the advantage, but because of the technical issue and cost, the number of malleables are more compared to the inflatable. So good afternoon. This is I would anyway. First of all, I would like to thank the all legends for giving me the opportunity as a young andrologist. My job here is to brief you about the penile implants. So mainly, I will focus on the indications and complication. But as you see the topics, I will just brief about the techniques and the other complications and how to manage it. So this is the final treatment options what we have for an individual having the refractory erectile dysfunction. I mean to say refractory means either it might be the organic problem or it might be the psychogenic erectile dysfunction. And if nothing works, we have tried everything like medications, injections, vacuum devices, etc. Then finally we have to counsel about the implants to have the normal sexual activity. It was introduced around 55 to 60 years ago in the US, but if we see our Indian scenario, somewhere in 1996, our respected Rupin sir has introduced first time our Indian made penile implant prosthesis. So if we see the annual number, it's around the 50,000 per year, out of which 50% is within the US. And our Indian numbers are very less because of the lack of awareness within the population as well as within the doctors. So generally we are doing around 700 cases in a year, and this is the last 5-year data you can see. So with this history, these are the indications of the penile implant surgery. The first one is refractory erectile dysfunction, which includes both organic and psychogenic erectile dysfunction. Few patients we will have the erectile dysfunction due to penile curvature. So in such cases also, along with the curvature correction, we do the implant surgery. The third and most important, recently I have seen alpha blocker induced ischemic priapism of 2-3 cases, where also nowadays as andrologists we choose to implant the early prosthesis if we compare with the late implantation of the prosthesis due to complications. So it's an important surgery for ischemic priapism also. The fourth one is very rarely we do the implant for premature ejaculation. I have seen only one patient having the refractory premature ejaculation, failed multiple medications, no use, at the verge of divorce and unconjugation. Then we have explained about the implant and then we have performed. Also definitely it's a part of gender affirming surgery. So what we are gaining by doing this surgery is we have the rigid penis. So with the rigid penis, the couple will have the good, normal, natural sex, and then ultimately it leads to high success rate. Studies saying around 90-95%, and ultimately we can reduce the divorces. And if we are dealing with the unconsummated marriages, then definitely it's a good choice as a end point. These are the contraindications. We don't do surgery when there is a local infection, and local infection means perineal or with, either perineal or urinary tract infection. Any lower urinary tract problem like stricture urethra or prostatic issues, we have to deal first and then we can proceed with the surgery. The other thing before surgery is we have to control the sugar and we have to advise to stop the smoking. That is very most important to prevent the post-operative complications. And if poorly motivated patients, we have to counsel for 2-3 sessions and then we have to proceed. We cannot directly go for surgery in poorly motivated patients. We have basically two types, malleable implants and inflatable one. Malleable implants will have the two silicone rods that we are placing in the corporal bodies. And in inflatable implants, we have either 2-piece or 3-piece. We have one reservoir, one pump, and the 2 cylinders. So in inflatable implants, the fluid will be in the reservoir. If we press the pump, the fluid will go from reservoir to the cylinders and patient will get erection. If we, after finishing the activity, if we press the pump again, the fluid will go from cylinder to the reservoir. Reservoir will be there at the suprapubic, the pre-radius space, just anterior to the bladder. So technically it's a complex surgery if we compare with the malleable one. So most of the time we do malleable surgeries. The only thing is it's easy to perform. The cost is also very low compared to the inflatable one, and it's a better reliable because the inflatable having the very high rate of mechanical failure because of the fluid. Okay, and anyway, so malleable also we have multiple options, but I just want to highlight our Indian implant, SA implant. It's cheaper compared to the AMS. And we can also adjust the length according to the patient. So it's easy for surgeon to choose the Shah implant. The inflatable, as I told, what is the best for this implants is we will get the very good erection and we'll have higher satisfaction rate along with the superior conceivability, flexibility. So that is the advantage, but because of the technical issue and cost, the number of malleables are more compared to the inflatable. The principle of surgery, this is for us as a surgeon, if any error in these steps, it will lead to dangerous complication. So what will happen if any dangerous complication, we have to take out the implants and then we have to redo surgery after 6 months. So very accurately we have to follow all this principle, which includes proper selection of the patient, proper counseling about how we do the surgery, what are the complications, what are the re-surgery rates, etc. So pre-operatively we advise to use the betadine scrub for 1 week. Then on table we do proper part preparation, painting, draping, proper scrubbing. We generally follow the no-touch technique, and we change the glove before opening the implant pack. So on table also we have to accurately measure the length of the corporal body, diameter of the corporal body, and then we have to select the size properly. Otherwise there will be a post-operative either erosion or extrusion of the implant. Post-operative principle is we generally continue the antibiotic for 2 weeks. Regular follow-up is must, because if we diagnose the infection, for example early infection, we can treat with the IV antibiotics and we can prevent the further more complications. And abstinence is very important for 6 weeks. Most of the time this kind of couples, because of the long duration of the abstinence due to ED, they will immediately start, after healing of wound, within 1 or 2 weeks they will start excessive sexual activity. I have seen one of my patients started the activity within 2-3 weeks, and that was also 2-3 times in a day. So the proper counseling, pre-op counseling and post-op, while discharge also will counsel about that we have to wait for 6 to 8 weeks and then we can use it. These are the basic steps. We'll drape the patient, open the corporal bodies after stitches. We'll check the length of the corporal body, as I said, along with the diameter. Then we'll flush the corporal body with the antibiotics to prevent the post-operative infection and to diagnose the urethral injury while dilatation. Next, we'll open the implants. We'll do the proper sizing of the implants. We'll put it into the antibiotic solution, and then you can see the end result will have the good, nice erected penis, which is for malleable, which is ready to use after 6 weeks. The only problem with this surgery is complications. So on table we have complication like urethral injuries, corporal injuries, or any other visceral injuries. That is, we can have the, if we follow the accurate and fine movements, then we can prevent all this stuff. But post important complications are very important. Most of the time there may be some hematoma, infection, abscess, etc. So then we have to, if the infection is very severe, we have to take out the implants, wash with antibiotics, give IV antibiotics for a few weeks, and then after 6 months to 1 year you can come back and do the re-surgery. The other issue is erosion and extrusion. So if there is a oversizing while putting the implants, the implant can come out through the glands. Okay, so these are the dangerous complications we may have. For inflatable implants, the main issue is malfunctioning of the assembly. So malleable having the easy to perform and less complication compared to inflatable. You can see on the right side of the screen, it's a glans necrosis immediately after implant. So I had to take out the implants immediately, debride the glans, and then you can come back after 6 months, sorry. The middle one is the erosion extrusion of the implants, and the on the left side you can see the abscess. So these are the preventive measures. What we follow, that if we focus on this, we can have the minimal complications. So we give proper IV antibiotic coverage. We'll put the catheter before surgery to prevent the urethral complications, adequate hemostasis to prevent the post-operative hematoma, accurate dilatation so that we don't have the erosion and extrusion post-operatively. Proper sizing is very important, and use of antibiotic solution while putting the implants. Of course, sugar control and the smoking is very important. So this is take-home message. Selection of the patient is very crucial in the penile prosthesis. Counseling is the key for better outcome. Following accurate surgical guidelines can minimize the post-operative complications, and if everything goes well, we have almost 95% of success rate in terms of normal sexual activity. Thank you.
Thank you for the wonderful presentation. Would like to request Dr. Ajian for felicitation of Dr. Nayan. Momento. Felicitation. All of them? Please bring the memento. Sir.